I'm very proud to welcome you to our inaugural webinar, which is put on by the Program and Practice Support Department here at the College of Family Physicians of Canada. We're going to be talking about the OA tool today. And I can tell you that last week at FMF, we did a little test run and everything was well received. And this seems to be a good tool at the right time for our patients' needs. Couple of housekeeping items. This is a webinar, but you will be able to put questions in the chat box that you see, and there will be questions periods throughout the presentation, and I'll give you some warning. We will also have polling questions. This is your chance to actually answer questions, which I'll then tie in some information. And it allows us to see what our practice patterns are and what ideas we have. Some of the polling questions are yes, no, or multiple choice, and others are open boxes. This hour, as a live webinar presentation, has been certified as a group learning program of the College of Family Physicians of Canada for up to 1 main pro credit. We are recording today, and this will be ready as of tomorrow for any type of asynchronous viewing for members who could not attend today. I will just mention my disclosures. So I am currently working at Toronto Rehabilitation Institute, and I am providing this webinar and the work that I've done as clinical lead on the OA tool as a volunteer contribution. I don't have any commercial interests or speaker bureau affiliations or consulting fees associated with this project. This is a really exciting project and one of our first partnerships on a clinical tool. The OA tool was a partnership between the College of Family Physicians of Canada, the Arthritis Alliance of Canada, and the Centre for Effective Practice. And in pulling together these three groups, we also created a working group of college members who, along with myself, provided the direction and the final impact of how this tool would be used in clinical practice. So I'd like to thank Dr. Pierre Frémont, Dr. Sahil Jain, Dr. Mathieu Lafontaine-Gobeau, and Dr. Victor Lunn for their participation in this presentation and tool development. The learning objectives for the next hour is I hope that you will be able to describe the OA tool to a colleague. You'll be able to utilize the tool in your own practice to help determine stage of osteoarthritis and provide a high-yield history and relevant physical exam. You'll be able to educate your patients on what is evidence-based management recommendations and to apply appropriate criteria for investigations and referrals. Let's start with a polling question. What percentage of your patients make an appointment to discuss osteoarthritis symptoms or management? I'll give you a moment as people start to put their answers in. Okay, thank you. And I will tell you the answer to that question is that about 15% of our visits are specific to osteoarthritis, but that number is growing. As the surveys come out every year, we will anticipate that we'll be at 25% of our practice dedicated to osteoarthritis management within the next 5 years and going up to 35% within the next 15 years. So what is osteoarthritis? Well, we know that it's a disorder of the full synovial joint. So that means the lining, the cartilage, the bone, the fluid. The fluid loses viscosity, the cartilage thins, the lining expands, and the bones show areas of stress. We know that the joints most commonly affected are knee, hip, and hand, followed by spine, shoulder, and ankle. Why do we need a tool? If we understand that osteoarthritis is extremely common, and that the most commonly affected joints are the hip, knee, and hand, then we can see that there is a need for a tool that will actually streamline our approach to a great number of patients with potentially multiple joints affected. The prevalence, as I mentioned, is increasing, but more importantly, the association with disability and with impact on chronic disease management is also part of the need for a tool to help us gain better understanding and increase patient function of those with osteoarthritis. So despite what we know about osteoarthritis and how common it is underdiagnosed, it is under treatment, and there is a delay in seeking care. What does that mean? There are missed opportunities. The average time from symptom presentation to diagnosis is currently 5 to 7 years. Those are valuable years to help a patient understand how to manage symptoms and how to avoid further deterioration, or at least reduce the pace of it. So by improving our screening techniques and our advice to patients, we can optimize function, mobility, and independence. Let's do a quick assessment question. True or false? Weight reduction among the obese, that is over 30 on the BMI scale, is a prevention strategy for hip, knee, and hand osteoarthritis. True or false? We'll give you a minute to answer this question. I love it. 50-50. All right. I often get the question as to why would weight reduction help hand osteoarthritis? But in fact, what we know is that we use our hands to push ourselves out of a chair, to hold on to a railing, and that actually is impacted by increased weight. We also know that general weight reduction of actually only 5% of body weight makes a significant difference to pain and function. So the impact of weight loss on management of osteoarthritis is significant and is a cornerstone of both prevention and treatment. Let's go to another polling question. Osteoarthritis has been identified as a direct cause of which of the following conditions? With an S, you can actually choose all that may apply. And again, we'll give it a minute as we start to bring in our answers. Okay, so we can see the screen changing. The bottom line here, and thank you for your answers, is that osteoarthritis is associated with every chronic disease. And so when we look at the presence of whether it's cardiovascular disease, mental health disorders, diabetes, COPD, the presence of osteoarthritis affects the management of that condition. And remember, we're talking about a disease that affects mobility. And we know that movement and mobility is key to optimal treatment of chronic diseases. And last polling question before we get into the evidence. Which of the following evidence-based management strategies do you offer to your patients now? Let's do this as a polling question and take a look at whether or not these are current strategies for your practice. Okay, we've got our answers coming in. And I will say that these 4 items are one of the most important management pillars for this tool. Joint protection is something we don't actually learn about, so I'm going to talk a little bit more about that as we get into the evidence. Heat is absolutely useful for osteoarthritis, and duloxetine is now our second-line drug for management of chronic osteoarthritis. Neuromuscular exercise is an emerging area of very positive results of using balance and dynamic exercise for joint stability. So, how does osteoarthritis impact your practice? Well, first of all, it is not a disease of the elderly. It is really a disease of the continuum of the life cycle. So you may have a 28-year-old with an ACL tear. They have a high probability of developing osteoarthritis, whether or not they have surgery. When do you tell them? How do you tell them? When do you start prevention? A 45-year-old with recurrent intermittent pain, normal x-ray if done, normal exam, still needs to be advised on weight management and stabilizing exercise because they are starting to show symptoms, although the disease has not progressed. And a 62-year-old with early osteoarthritis stage symptoms actually needs a comprehensive assessment and an ongoing maintenance plan, just like we would in a patient with early onset diabetes. And the 75-year-old who is diabetic with a history of cardiac disease and has osteoarthritis needs good support, modified activities, pain management in order to do the appropriate treatment and rehabilitation for cardiac disease. So we can see that osteoarthritis is not only prevalent in our population, but throughout our practice and all ages, there is a role for good education. Let's look at the tool and how we have designed it. First of all, in developing a tool, it does take about a year of work. We need to look at the current resources, the evidence, what we know about gap assessment, what we know about the needs and education of our practitioners. Then there is the content development, usability, trials, and prototyping to ensure that the tool is actually easy to use, practical, and appropriate for clinical practice time management. Then the dissemination and the evaluation. So we are in the dissemination process of the tool, and we encourage you not only to use it, but to provide us with feedback and evaluation. When we look at evidence, we are looking at all levels of evidence, including current clinical practice guidelines internationally, but as well as systematic reviews and randomized controlled trials. And this helps us get a broad perspective because we cross-reference and correlate the actual resources and evidence so that we are giving you a very comprehensive but targeted summary of evidence-based literature. What literature did we use? We certainly went to the American College of Rheumatology, where they have had consistent and progressive guidelines over the last number of years. ORSI, which is the Osteoarthritis Research Society International, which develops many tools and practice supports based on clinical research. The European League Against Rheumatism, which recently put out a very strong guideline, especially around imaging. And then within Canada, we have British Columbia and Health Quality Ontario that have practice support branches and have developed in BC guidelines and in Ontario standards for osteoarthritis. Let's look at what the evidence says. From the American College of Rheumatology in 2012, and we're expecting the 2018 guidelines within the next few months, we see that there is an approach of non-pharmacological and pharmacological management, and that is a very important evidence-based recommendation, is that this condition is best served by using an integrated approach of non-pharmacological and pharmacological. What does non-pharm mean? Predominantly exercise, weight loss, gait assistance, heat, and self-management support. Pharmacological, pain management, whether that be within a drug or whether that be an injectable. And then back to 2012 came the recommendation to use duloxetine. The hyaluronic injections were also recommended at that time, and you'll see as we go on that right now the evidence is inconclusive for hyaluronic acid, and there is more research required, especially to determine specific stage and appropriate patient. And in the hand, we found that when we looked at the American College of Rheumatology guidelines, cortisone injections are not recommended in the hand, and joint protection, such as splints or supports, especially for the thumb, can be very useful. In 2014, ORSI put out the knee non-surgical management guidelines. And in that, they divided their recommendations into recommended, inconclusive, or not recommended, which helped clarify some of the management options. Again, duloxetine was recommended as second-line pain management, especially with chronicity of osteoarthritis pain or multiple joint involvement. Inconclusive evidence around opioids and tramadol. And at this point, I would say that opioids would not be recommended in most cases of management of osteoarthritis. We now know that also not recommended includes electrical modalities and risdronate, so that we are starting to gravitate to measurements and to management that we know have great benefit. Throughout the various guidelines of both ORSI, American Rheumatology, and now the Health Quality Ontario, it is clear that arthroscopic knee debridement is not performed even with those with significant radiological osteoarthritis. So this is a message that we have to also deliver to our patients, that surgical debridement and lavage is not indicated. ORSI went on with their systematic review of recommendations and looked at the chronic osteoarthritis management and found that education, self-management, exercise, assistive devices, and heat, again, was strongly recommended. And this may sound like something we already know, but having that conversation with a patient about using a cane, possibly a walker, when to use it, when not, how to offload the knee by using an assistive device is a very valuable discussion. When to use heat, ideally 20 to 30 minutes after activity, once to twice a day, can be very helpful. And the inconclusive evidence around braces, injections, herbal supplements, and acupuncture has remained in that category. In 2017, the European guidelines looked specifically at imaging. And in that, they found that imaging was really only indicated, that is, would only change management, referrals, or treatment if, in fact, we were dealing with a patient who had an aggressive progression of their symptoms with changing reduced disability. By reducing their function, increasing disability, that may be an indication for an X-ray. Remember that X-ray is the ideal image if you are going to image either an atypical presentation, failure of success with management, or aggressive progression, because it will show the bones best. If you are thinking that there is a soft tissue component, a cartilage component, then you want to use an MRI or ultrasound. Ultrasound is helpful for soft tissue tendons, and MRI helpful if we're looking at ligaments or cartilage or meniscus. Sometimes imaging is needed if you're going to do ultrasound-guided injections for a complex patient, perhaps an obese patient, perhaps multiple joint or significant malalignment, because you can then, or the radiologist can then correlate the ultrasound with the X-ray image. This is just an example of the BC guidelines, which is on their bcguidelines.ca website, which looks at diagnosis, appropriate investigations, and management. and the Ontario Health Quality Guidelines, which provide 10 standards for clinicians to aspire to, including a clinical assessment versus radiological, comprehensive management, patient education, exercise, promotion of physical activity and weight management, as well as a pharmacological plan and referrals as required to other health professionals or surgeons. So what are the gaps that we currently have? Currently, within the guidelines, we don't have a common approach to assessment and examination when a patient has more than one joint involved. We don't have a good clinical approach in any of the guidelines to office-based examination. And we don't have a good integration of key messages for patients to help with self-management and education. We don't have a good way to stage clinically where our patient's level of arthritis is, and consequently we often rely on imaging. And we don't have a good way to actually understand the non-pharmacological interventions from primary care clinicians' offices. So let's actually have you provide an open box question here. Any questions you might have about the current evidence that I've presented before we move on to actually showing you the tool. I'll start with a definition of neuromuscular exercise. Excellent. Neuromuscular means brain and muscle. It means that there is a coordinated response from your whole body to produce a movement. So balance exercises are a good example of neuromuscular exercise. Moving slowly from sit to stand with a mindful, conscious engagement of muscles is a neuromuscular exercise. And I'll show you in a few minutes the GLAD slide about our national GLAD program, Good Living with Arthritis, that is based on neuromuscular exercise. What is the number needed to treat for duloxetine for OA pain? Somewhat skeptical about this recommendation. Very good question. So let me first preface that by saying that when duloxetine came into use, it was used for chronic pain syndromes. And that was really around widespread pain, pain that was constant, pain that was interfering with function. When patients fit into that same definition in osteoarthritis, duloxetine is often indicated. There have been good studies where the actual label indication for duloxetine is for chronic osteoarthritis management. So, number needed to treat, I'm going on memory here, but I believe that it is 7. I can look that up and we can maybe follow that up with an interaction. But I think when we look at the process that duloxetine has gone through, I often get the question, how do you put patients on duloxetine without side effects? Remember, this is second-line drug, but I will often start them on 30 milligrams at night for 2 weeks, have them accommodate to the drug, and then add a second dose of 30 milligrams. So they are on 30 milligrams twice a day. If no side effects and they've accommodated, well, I can move it to 1 dose. Any evidence for ice or cold? So ice or cold can be a pain reliever, a spasm reliever, and a swelling reliever. But for chronic osteoarthritis pain, heat is much more effective. When would I use cold or ice? I'll tell you, with a swollen joint that is acutely traumatized, not a swollen joint that is chronic, ice with compression can be very helpful. Where does topical diclofenac fit in? It does fit in, especially for the knee joint. There is an indication for diclofenac for knee osteoarthritis. The studies will show short-term benefit of up to 12 weeks. There are some initial studies on the hand, especially in the thumb, which have been shown to be positive for shorter time periods. Under recommended treatment was their oral corticosteroid. That was a previous recommendation for multiple joint and acute presentation. Some of the rheumatologists may still use that. It would be for a more aggressive presentation and an inflammatory presentation. Would oral corticosteroid therapy be recommended? So, same answer. Is there for acute flare-ups? And would a corticosteroid injection be safer? So remember that the corticosteroid injections are best for knees, difficult to get into hips without imaging, and not recommended for hands. So we're really looking at the individual patient to understand their risk of side effects and to understand which joint, and therefore do we use a topical, an oral anti-inflammatory, an injectable corticosteroid, and in some cases, more aggressive, more acute and multiple joint, potentially short-term oral corticosteroids. Let's move on to the next slide. I love your questions. We'll have another couple question periods coming up. So let me just give you, first of all, with the OA tool, 6 points that will help you understand if this is going to fit into your practice. First of all, the history is the same for all patients regardless of their examination or joints affected. And then the exam breaks up into lower extremity and hand. So we've tried to tailor it so one tool, one approach can be used for essentially 3 joints. The second key point is the emphasis on non-pharmacological and pharmacological in an integrated approach. The third is staging, and we have labeled the stages of osteoarthritis as early, moderate, and advanced. And that is based on consultation and on review of the literature, but also on a significant input from patients through trials, through qualitative studies, which looked at the word mild and patients feeling that that minimized their symptoms, where early is more appropriate for stage, and advanced being again appropriate for stage, where the words end stage did not give much hope for treatment and often left the clinician and patient with only a referral for surgery. So they are again early, moderate, and advanced. Next, evidence-based education and exercise. And if you haven't downloaded the tool already, feel free to do so. It's on our college website. It is also on the wellhealth.ca. And you will see that the way that we have laid out the management, I find I can give that page right out to patients and circle the management that I'm recommending. Fifth point is a comprehensive approach. So the tool is not used just on visit 1. It can be used anywhere through your continuum of care and can be used for follow-up or for baseline. And we have tried to integrate key messages so that you have some wording available to your patients for their questions. Again, here are 3 opportunities to download the tool, of course, free of charge, and it is in a color or black and white copy. So if we look at the tool, the first question is, where is your patient's pain? That's very important, because we're trying to already with that first question use clinical decision making and determine, is there an inflammatory component or is this an osteoarthritis? The blue joints are osteoarthritis and the orange joints are systemic inflammatory arthritis. Not to say that you might not have some crossover, but we're looking at patterns. If in fact your patient has multiple joints and they're fitting into a pattern, you want to be aware of whether or not that's an inflammatory pattern. And question number 2 is to even dig deeper into that inflammatory potential. Does your patient have morning stiffness in their joints that lasts greater than 30 minutes? If in fact they have an inflammatory pattern and they have morning stiffness of greater than 30 minutes, then you exit this tool and you look at the inflammatory questions that help you determine the possibility of inflammatory arthritis. And those questions are in many other tools. We have put them here in this tool for a trigger for you. Pain increased with rest or immobility, persistent joint swelling and tenderness, joint warmth or erythema, and of course, unexplained weight loss and more systemic problems. So, rule 1, sort out what's inflammatory. And I'll just mention that again by saying the delay in diagnosis around inflammatory arthritis is still quite long. And the introduction of DMARDs to treat inflammatory arthritis is actually quite an advancement. So by using biological disease-modifying anti-rheumatic drugs, we can actually help our inflammatory patients much earlier. So goal 1 is to rule that out. Once you have done that and you are now thinking this is osteoarthritis, I then want to know, is your patient's joint pain generally related to activity? And if, again, it is not related to activity, you're going to think about red flag. But if it is, you can proceed to question 4. What is question 4? The description of pain. And by actually asking your patient what their pain experience is, how it affects their activity, you'll start to see that they already start to fit into a stage. So whereas that patient with early osteoarthritis will be characterized by intermittent pain, often associated with activity, and doesn't impact on their usual daily activities, although they may have pain intermittently. Moderate is the pain becomes a little more predictable, and it may be associated with locking or buckling. There may be some other joint symptoms, and it can become longer periods of constant pain with shorter periods of no pain. Advanced is usually constant dull aching, and again, symptoms of immobility, symptoms that affect daily activity where in fact the patient is now modifying to manage stairs or to manage activity. Red flags, think of infection, inflammation, fracture, and tumor. So those are 4 of the common red flags, most common red flags for joint pain. And this table gives you some of the potential differential diagnosis as well as investigations. So if your patient has pain at rest, doesn't mean they have a red flag, but I want you to think about it. If in fact their pain is related to activity, go ahead and stage. Question 5, is your patient avoiding all activities due to pain, stiffness, or weakness? In this question, I'm looking at either that patient has an advanced osteoarthritis presentation or perhaps a chronic pain syndrome. And so I really want to see if there are psychosocial risk factors for developing chronicity, or are we into a chronic condition already? And the yellow flags are based on the New Zealand yellow flags, which are really looking at whether the patient is fearful of activity, whether they rely on passive treatment, whether they have an emotional investment in their pain, and whether or not they actually feel that they are going to improve or not. So these are the same yellow flags that we would use in back pain. Question 6. Now this question is specific to joint pain and osteoarthritis. And this is really to try and detect instability. Remembering that joint instability is the cornerstone to faster advancement of stage of osteoarthritis and unstable knee causing falls. So we want to pick up on instability. Is your patient experiencing symptoms of joint instability such as giving way, locking, or repeated clicking? And if no, you proceed with the tool. If yes, we are suggesting that you do need to do a more complete physical examination, especially related to meniscal testing. I'll show you that in the exam we have a meniscal screen, but we suggest that you do ligament and meniscal testing completely if they are showing signs of instability. And the last question for the history is number 7. Does your patient have any chronic disease comorbidities, including sleep disorder and/or mood disorder? This is very important because your management is of the whole patient and you want to take in any other elements of chronic disease or sleep-causing muscle fatigue, mood inhibiting motivation for activity, since exercise and activity are the mainstay of non-pharmacological treatment. So, the actual history is 7 questions. What am I trying to do in these questions? Just looking at how this may change from your current assessment, definitely trying to start the staging early, trying to rule out inflammatory arthritis, trying to identify instability, and trying to look at any multiple joint symptoms and comorbidities. Let's go into physical exam. Now, I'll tell you, the physical exam is relevant and focused. This is an osteoarthritis exam. This is not a complete lower extremity exam. Your local therapist may do much more testing if they're trying to determine further management options. If you have other symptoms, you may do more extensive testing also. But this is what our experts have decided is appropriate for identification of osteoarthritis and its staging. The first, of course, is to look at weight so that you have an idea of weight and BMI, because that's going to be part of your management, and blood pressure, because that may affect your medications that you prescribe. Next, you're going to look at alignment. Your alignment is really to know whether or not there is increased risk of a certain compartment in the knee or hip having overload because of alignment, and whether bracing may help. And then you want to look at gait, and in particular limp and distance. Does your patient limp when they're walking greater than 5 minutes? How far can you walk? Do you ever have to use a cane? Do you ever limp? That piece doesn't take you long to do, and that really gives you an idea of what's happening with both hip and knee joint. Then focus on knee swelling. The hip, it is extremely hard to determine if there's swelling in the joint, but the knee, it's very easy. And so by doing a bulge test, you can see if there is swelling. And if there is minimal or no swelling, but still symptoms, that would be an early osteoarthritis. Whereas if the joint effusion, it has been constant or chronic, it's likely a more advanced stage. The last part of the lower extremity exam is strength and range. We've combined strength into what's called the sit-stand test, and that is simply asking your patient to stand from a seated position in a chair, sitting deep into the chair, without the use of their arms. And if in fact they can do 15 repetitions in under a minute without any difficulty, their strength is good and they would be in the early stages. If in fact they can only do 1, 2, or 3 repetitions in 30 seconds, then that is more indicative of weakness and that their joint swelling, their joint stability may be affecting their strength. And if in fact they're unable to get out of the chair without the use of their arms, then that would be a more advanced stage. So use of their arms means using the armrests. That's all you have to do for strength. You don't have to worry about quad and hamstring and glute med testing. This is called a functional strength test. Range, you are looking at hip flexion, hip internal rotation, and knee flexion. Those are your 3 range of motions to determine if you have had loss of range plus or minus symptoms. And again, we have put them into stages based on their range availability. That's it for the lower extremity exam. Now for the upper extremity exam, we have you find out which joints are sore. So you may have done that already in your history, but now you're looking at any deformity and you're looking to see, is there any swelling or tenderness? This is really a joint count, but it is used in osteoarthritis to be able to understand the effect of either deformity, swelling, or tenderness. Most commonly, the thumb joints are going to be affected the most. We then have you do a squeeze test to look for any multiple joint pain. And in order to rule out de Quervain's, which is going to be the most common soft tissue condition in the most common joint, we have you wrap the patient's thumb in their own fingers and passively ulnar deviate their wrist so that in fact you are putting a stretch on the extensor pollicis longus. And that is a quick screen for your de Quervain's test. For strength testing, we're asking you to do grip and pinch. And by doing grip and pinch, comparing right to left, you can determine strength and function as well as osteoarthritis stage. So your physical exam, even if you were doing 3 joints, is still going to take you less than 5 minutes. And if only doing upper or lower, you're probably in the 2.5 minute category. We want to make sure that your time with the patient is for management. High yield history, focused exam. What about imaging? If your patient has had imaging, collect that information. If your patient has not had imaging, then you are determining, is there a reason for imaging? Failure to respond to treatment, referral to rheumatology or orthopedic surgery, or aggressive and or atypical presentation. And if you do order an exam, we have used the Kellgren-Lawrence radiographic criteria to help you stage that into early, moderate, or advanced. Referrals, we've given you the criteria of when a patient is appropriate for referral, not just to surgery and rheumatology, but also to a pain specialist, a sport and exercise medicine physician, or a rehabilitation therapist. And in our tool, we have done a management matrix where we have divided into lower extremity and upper extremity, recommended, not recommended, inclusive, pharmacological, and non-pharmacological. This is just a brief summary of the management matrix, but it allows you to look at all aspects of joint treatment and what is recommended at one glance. I'm going to just mention briefly in management, I know we had questions around neuromuscular exercise, and exercise is the most evidence-based treatment for osteoarthritis. And I want to emphasize here that often patients will say, but it hurt, so I stopped exercising. And often physicians will say, if it hurts, stop exercising. The evidence does not actually say that. The evidence says if the pain is low grade, localized, and without any other symptoms such as swelling or instability, continue to be active, you may have to reduce, modify, or rest for a short period, but don't stop exercising. In many cases, a patient will actually improve during that exercise section or over time and have less pain with exercise. What type of exercise? Strengthening and stretching are logical, but really any type of exercise is beneficial. We know that the evidence for it is quite extensive, whether it is aquafit, land-based exercise, or resistance, even the mind-body exercise such as Tai Chi and yoga. And GLAD, which is a program from Denmark, which is the D in GLAD, has come to Canada under Bone and Joint Canada, and this is 6 weeks of an exercise supervised class twice a week, so 12 sessions altogether, integrated with education, teaching a patient functional neuromuscular exercises that they can do on their own, that has been evaluated and found to reduce pain, increase function, and even reduce surgery. Let's do a couple polling questions. Actually, this is open period questions. So if there are 1 or 2 questions, I'll take them now, and then we have a quick case to do. So any questions on the tool before we move into the case of Danielle? I'm just going to give it another minute, and as we do that, I will say that I have found that our usability studies have shown that, in fact, the tool takes a little bit of reading, and we've added an education page in there for you, and then application of a few patients before you actually start to feel like this is part of your clinical practice, which is a very quick ramp-up time. Be very interested to hear what actually happens in your practice. Could you explain joint protection? Yes. So joint protection means that we are promoting the joint to be active and the person to be functional while protecting a joint and reducing the stress on that joint. So in the thumb, that might be a splint In the lower extremity, that might be a cane. It may be saying to someone, you know, you're going to have to divide your laundry into smaller baskets that you bring up the stairs because that heavy basket is putting extra pressure on your joint. So it is both activity modification, joint stabilization, and offloading weight from joint in order to produce good activity with less stress. On average, how long does it take to apply the tool? On average, we are looking at for a first-time assessment, about 15 to 20 minutes, and for follow-up, 10 to 15 minutes, with the history being approximately 5, the physical exam 2 to 5, and management being your 5 to 15. Thoughts on platelet-rich plasma? I saw stem cells in there also. Inconclusive. I know that research is being done, but currently we don't have conclusive information to say that it works in all patients. There is some research, especially in the area of the knee, around platelet-rich plasma that's looking very promising, and around stem cell. But I'll have to say inconclusive. Any messages that you share with patients about moving and exercising with pain? Absolutely. So I usually say movement is much better than stationary activity or than no movement. So movement is medicine. Movement is part of treatment. I have to get that concept across. Then I say start low and go slow. What are you doing now? How far can you go? Let's increase by just 10% every other day. Let's break up your activity. Let's look at what's difficult, break them down to components, and see how we can keep you moving, but in a smarter way. Last question. Do you recommend joint alignment braces in patients with significant valgus or varus deformity? Okay, here's the key here. In your knee, you have 3 compartments, anterior, medial, and lateral. If all 3 compartments are affected, whether that be on x-ray, whether that be in mobility or lack of mobility, or whether that be related to a lot of swelling, you have no compartment to unload. So the ideal patient for an alignment brace is where there is a non-painful, mobile part of the knee, which is often the lateral compartment, where the joint brace can actually shift some of the weight. So in someone who is varus and bow-legged, we're going to shift medially. And in someone who is more knock-kneed, we're going to shift laterally. And that's your key. Great questions. Okay, Danielle, 66-year-old woman. She would like a cortisone injection. Her previous doctor retired, but she did benefit from a cortisone injection before. The last one she had was a year ago, and it lasted her quite a long time. She's been managing with acetaminophen since then. What other questions do you want to ask her? Let's start there. Open text, any other questions you want to know about Danielle before you decide if you're going to proceed with an injection. And we'll give you another minute. The responses are coming in. Okay, so we'd want to know about what other medications. And I think medications is a good place to start. How many? What's your dose? What's your duration? And of course, also any other treatment. Screen again for inflammatory. Totally agree. Just because someone has responded to cortisone in the past or has been told they have osteoarthritis in the past doesn't mean you stop screening for inflammatory. Absolutely great point. Previous injections in the same location. We used to have a mantra, 3 injections per site per lifetime. The rheumatologists don't stick to that as much anymore. It's more about response and full management. Comorbidities, previous imaging, other management that she's tried, and what about exercise? Absolutely. So we want to ask questions that are going to help stage That's the description of pain and activity. Absolutely red flag questions, including inflammatory, yellow flag questions, and anything around instability and chronic disease. Would you do imaging in this patient? Now, she's 66. I will say that her level of activity has not changed over the last couple of years. She walks. She does not do sport. Her knee does bother her if she has to run for the bus. But other than that, she hasn't changed any other activities. Would you do imaging? Remember that clinical imaging is up to the clinician. So in a tool, we are providing you with evidence and guidelines, hoping to help you make the decision. You may find reasons why that are outside of what we are recommending, but we do want to emphasize that imaging is not required if the patient is showing a typical presentation of osteoarthritis, because it won't change your management. Follow-up of imaging is also not required. So she has had, in this case, an image before. Follow-up imaging is not required. We used to do baseline and follow-up. We don't anymore. What pharmacological agents would you use for her pain? So we brought up the issue about what else besides injection. Let's see what you would like to provide her with. And responses are coming in. An NSAID and PPI? Absolutely. I think that using an NSAID would be appropriate. I will say that there is increasing evidence that acetaminophen in a large number of patients is no better than placebo. NSAIDs do fare better than placebo in many patients. There is some work around the combination of acetaminophen and an NSAID. But having said that, I also appreciate your patient may be at risk for gastro adverse event, may be elderly, and you might feel that acetaminophen is safer. And is placebo a problem? Maybe it's worked for them before. Topicals, it would be worthwhile to try a topical because her problem is knee related, and we do know that a topical may be useful, but has to be used 3 times a day to be effective dosing. Duloxetine, so this is where you may look at it. Again, if her symptoms are more intermittent and her stage is early to moderate, you may want to wait and try some non-pharmacological options in addition to her pharmacological before using duloxetine. I will say that I have had patients who use duloxetine for 3 to 6 months, get a better grip on their arthritis pain, and in fact increase their activity and exercise and go off duloxetine. So it doesn't have to be lifetime. So medications, we've talked about oral NSAIDs, topical, and steroid. Steroid injection is still indicated as an effective therapy, and we know that it gives between 4 and 12 weeks of pain relief, usually not a year. So if in fact your patient has had long-acting relief, it makes me think they've been doing other things right that you want to actually emphasize. Back to Danielle. So over the last 3 months, she's noticed some intermittent swelling and aching that occurs towards the end of the day, especially in the anterior knee around the patella. She has not noticed any giving way or locking. She does feel like her knee's a bit weak and she can't always trust it. She was previously an avid skier and runner, but now her activity is a daily walk with her dog for 15 minutes. She does recall having a right knee injury in the past in a ski accident that occurred in her early 20s. She recalls seeing a doctor in the emergency room, and her recovery took a few months and she went to a physiotherapist. Of course, we start to think, was there a partial or full ACL? Does she have the beginnings of some instability? What's happening with the fact that she has had occasional swelling? What stage do you think she's actually symptomatic for? Here's your chance: early, moderate, advanced. And we've got some saying early, a few other responses coming in. I think in her case, she could be early to moderate. Her swelling is a concern for me. I'd want to track that a little bit more. Her pain is definitely intermittent. She has modified activity, but she's still walking. She's still doing her daily activities. There may be reasons why she's no longer doing some of her sports. Is there such a thing as early to moderate and in between stage? Sure, absolutely. And we often say that. You have early osteoarthritis, you're at risk for moderate, there's some symptoms showing up. You can certainly say that. I'd want to go to her physical exam because that's going to really help me. Based on her history, many of you said early, and I agree. I'd want to make sure that she had not lost range of motion, especially in extension or flexion, and that she could still do that sit to stand a good 15 times. What other information do you need? This is an open text question. Or, sorry, do you need more information? Yes, always. So, I just want to emphasize here as we go through the tool, we're focusing on osteoarthritis, but don't forget about your differential. Every follow-up visit, as you connect your history to your physical, think about your differential, whether that may be gout, whether that be an avascular necrosis of the hip, whether that may be a septic arthritis. What examinations do you expect to find in Danielle? This is an open box question, and we'll give you just a minute. So we might find a high joint count if there's something systemic. If we're looking at systemic, we might find an effusion or swelling. And in her, it's probably a moderate effusion. I'd like to see her walk. I'd like to see her range. I'd like to see what happens with a quarter squat in standing position, which is our sit-stand test. And we actually find with her that she has no effusion today. She can do her sit-stand test, but she's got some patellar pain, some anterior pain. And that actually affects the number of times that she does her sit-stand. So she only does it once and then says, this is too painful for me. Her hip range of motion is full and does not refer to the knee. Remember that hip pain can refer to the knee, and it's the hip joint. And her meniscal testing is negative. So Danielle, over the last 3 months, has become concerned also about some aching in her hands. Better days, worse days. Her hands are stiff in the morning, and she did take up knitting and finds that she gets some discomfort and lack of mobility after she knits. As the appointment progresses, she points to her knuckles and feels that they are starting to increase in size. And she's noticed some bony prominences at the distal interphalangeal joints on the second, third, and fourth finger. No redness and no swelling. So is there some early osteoarthritis of her hands? What kind of non-pharmacological interventions could you use? And this is our last polling question. I think we're more comfortable with non-pharmacological interventions in the lower extremity than we are in the hand. So I'd be interested to see what you feel might help her. Heat, absolutely. Heat can be delivered in many formats. There are home wax baths. There is hot showers, microwave bags, all kinds of ways to put heat on, including soaking in hot water. A splint? Yes, now I would look for thumb instability or thumb lack of function to see if a splint would help. Stretches, absolutely. Actually trying to stretch the hand, strengthen the hand can all be useful. fingertips to palm, fingertips to wrist, and thumbs to fifth finger. So moving our hands, warming them up just like we do our legs. Assistive devices for jars. So this is a good example of joint protection. Whether it is a rubber squeeze that goes on top of your jar lid to help you get a grip, a larger pen to help you get a grip without as much joint compression, elasticized shoelaces, all of these are good examples of joint protection. So when we look at non-pharmacological management, we're still looking at overall exercise, joint protection, heat, and self-management. And I will say anyone with osteoarthritis can have, in addition, anxiety, sadness, and depression, and cognitive behavioral therapy is very helpful for helping them deal with the larger issues of changes in role and function. Evidence-based treatment is just as you have said: exercise, assistive devices, walking aids, joint protection, heat, analgesics, including duloxetine. Where does Danielle go from here? We need to make that bridge to self-management. We need to allow her to understand early detection of any emerging symptoms. We need to have some integrated follow-up in any visits that she comes for, and a focus on function so that as she ages, she continues to be active. Osteoarthritis is a partnership between patient and physician. It really is an opportunity for you to work with your patient, to educate them, and for them to help you understand what their functional limits are and what their abilities are. I call it joint custody. We need to take care of our patients' joints, and they need to help us with that. Thank you so much for joining me today. Thank you for your interaction, for your answers. I feel like you're right here in the room with me. We will be following up with the asynchronous version of this starting tomorrow. If you share it with your colleagues, and please download the tool and provide us with any feedback you have at the Program and Practice Support Department here at the College of Family Physicians of Canada. Thank you very much.